Good evening, everyone. Respected Dr. Urvashi Tanwar, ma'am, members of IADP and dear doctors, we welcome you back for another episode Learn from our master series. Good evening, everyone. Respected Dr. Urvashi Tanwar, ma'am, members of IADP and dear doctors, we welcome you back for another episode Learn from our master series. Good evening, everyone. Webinars is definitely so far. Like our Instagram and Facebook pages. We are very humbled to see your positive feedback. For those who are attending our webinars for the first time today, we will just give a brief introduction. Instagram we are the International Association of Primary to see your positive feedback. Those who are attending our webinars just for the first time today, we will just give a brief introduction. For we are is established history. Various webinars and workshops to enhance the skills of dental professionals. Various webinars and workshops to enhance the skills of dental professionals. Without wasting more time, I would like to invite Dr. Urvashi Tanwar, ma'am, for today's discussion. Without wasting more time, I would like to invite Dr. Urvashi Tanwar for today's discussion.
Thank you, doctor, for the lovely introduction. I just want to check one thing if I'm audible or not, if my voice is clear or not. Is my audio good for
I just
everybody?
want to check one thing if I'm audible or not, if my voice is clear or not.
I think there's a double sound.
My audio good for
Dr.
everybody.
Juna, Dr. Juna, can you please check because the audio is not coming clear, like it's echoing.
1 second.
Maybe we are live streaming on YouTube. I'm not sure.
Juna, can you, yeah, Dr. Juna, can you please check because the audio is not coming clear, like it's echoing. What about now, ma'am? Maybe we're live streaming on YouTube, I'm not sure.
Dr. Juna, shall we continue?
Yes. Yes.
Yes. Participants, is it clear now? Is there no echoing anymore? If it's clear, just let me know. So I can go ahead, and if you can see my screen.
Yes, I can yes. See. Yes. 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 Participants, is it clear now? Is there no echoing anymore? If it's clear, just let me know.
There's
So
still a lot of
you
echoing,
can
Dr. Juna.
yes, I can hear. Yes.
Dr. Juna, you'll have to do something. I can hear the whole thing again, like it's very distracting.
Something I can hear. Second, are you doing this?
Um, I can't hear what you're trying to say.
Ma'am, 1 second.
Yeah.
Are you doing this? Okay. 1 second. Yeah.
Okay, I'm gonna start now. I hope I'm clear and there's no echoing now. So participants, please let me know in the chat box if I am audible and if there's no echoing as well. And we will start. Audible, currently fine. Okay, perfect. So I would like to start with this quote that a good access cavity does not fight dentine, it negotiates with it. And in today's seminar also, I'm going to talk mostly about how we're going to negotiate with the tooth and make an access cavity that is both practical, sensible, and we're doing it in a very mindful way. Because we do not want to take anything excess from the tooth than what is already needed. Okay. So today's topic is strategic access, the blueprint of endodontic success. We've all been taught the traditional way of preparing an access cavity, but the question is, why do we need newer concepts then? You know, because the truth is that conventional designs often come with problems, which is unnecessary loss of tooth structure, missed canals, or reducing the long term survival of the tooth when you end up destroying and gouging and taking more from the tooth than is needed. So modern endodontics is all about being more conservative, more biologically driven, and yet equally efficient. And today we'll talk about these guidelines, these newer approaches, and these unusual pathways that still lead us to the same destination, which is successful, lasting endodontic treatment. So for those who don't know me, I'm Dr. Urvashi Tawar, a restorative dentist and endodontist by training, and a passionate advocate of minimally invasive dentistry. I run my own practice, Ashirya Dental Care in Delhi, where we focus on predictable, long-lasting, and aesthetic dentistry with a special love for rubber dam isolation and bonded restorations. Teaching and sharing has always been my happy space, so I'm excited to be here with all of you today. So we all know that access is the first and arguably the most important phase of root canal treatment. It is basically allowing us to get to the apex of the tooth, which is the goal of the treatment, to clean the entire system. If you do not begin right, there is no way that any of the steps that follow are going to lead you in the exact way to a successful endo than the right steps will. So, a well designed access preparation is very, very essential for good endodontic results. And without adequate access, instruments and materials become difficult to handle, in the sense that if you're going to do something, if you're going to make an access and you don't remove the dentine shelf, if you make it extremely constricted, you make it too much ninja, too much conservative, and you're putting more stress on the instruments and end up probably perforating somewhere or transporting the canal, or end up in instrument separation, then what good have you done? You've ended up making the treatment worse than it was supposed to be. So you have to make sure that the access is in a way very, very practical and done in a way that is efficient both for the tooth as well as for you. you know so without all this, it'll be very difficult to handle highly complex, and we all know that the root canal system is a complex place. So we need to make sure that our access is right. And for this reason, what we have to do is strategically extended endodontic access has to be made. And what do I mean by that? Where we are doing the access cavity in such a way that we don't unnecessarily weaken a tooth. And what this will aid in is you will get direct line and access to the apex, which is your convenience form. Because basically, for your convenience, for your materials and instruments and equipment to reach the apex, you are making this particular access cavity. You know, then you also have discovery of internal root canal anatomy. If you are doing a access cavity for a maxillary tooth, maxillary molar, and you want to shape the access cavity to incorporate an MB2, you're going to extend the access cavity only in that area so that you get a straight line access for MB2. You'll not extend the entire thing. And that, as we all know, is known as the clover leaf appearance, you know. So that is what I'm telling. It is basically driven by common sense, by logic. When you know all the factors, you will know how to do the access cavity in the right way. All this will help facilitate effective cleaning and shaping of the apical third, and in turn, it will help in achieving effective obturation as well. We all know the objectives of access cavity preparation. You know, I don't want to go too much into the basics. Today's seminar will not be about which burr to use, or we all know all of that stuff, you know, like which shape for a maxillary premolar, or how to make the access opening for a maxillary central incisor. We know those things. The basics is all done. I want to go a step ahead and tell you how to avoid the mishaps that is happening, or how to be more mindful and more smart about your access cavity preparations. You know, I don't want to bore you with a, lecture that is straight out from the book, like something that I've taken from Cohen or Engel, and just throw that. All of that you can read on your own. I have consolidated all of this information from the latest current concepts also, and from the past guidelines as well. And I'm going to give you a proper checklist for what you need to have in mind when you're doing an access cavity preparation. So feel free to put your doubts in the chat box if you have any related to access cavity. But today's seminar is going to be very general and very, just brushing up your concepts, and also, delving into the newer things that are there and whether we should be following them or not. So basics of objective, of cavity preparation is to achieve the straight line access to the apical foramen, to locate all the root canal orifices, and to conserve sound tooth structure, So this is also an objective of access cavity preparation. You cannot just be like, okay, you got straight line access, you have located all the canal orifices, but you have like this huge cavity where you could have done with a probably smaller, funnel shape. So it is like, the operation is successful, but the patient is dead. So we don't want that sort of a situation. We want to start and end with conserving the tooth structure in mind. We need to have that. We cannot forget that. So during patient treatment, whenever we are doing any access cavity, the clinician needs to consider many, many factors that will affect the ultimate outcome. In simple terms, these factors can be grouped into three categories, which are the operator needs, the restoration needs, and the tooth needs. The operator needs being conditions like the clinician needs to treat the tooth, What are these needs that I need when I'm doing the access cavity? I need these things. The restoration needs are like the prep dimensions and the tooth conditions for optimal strength and longevity. And the tooth needs are the biological and the structural limitations for a treated tooth to remain predictably functional. So traditional concepts actually mostly concentrates on the operator needs, like you make that funnel shape prep, or you do that extremely, big straight line access, you need it like really big and all those things, for de-roofing completely, clear visibility, accessibility, all of it is good. That was a traditional way. We can still do that. It is still a concept, but make sure that you don't overdo it, because overdoing it means removing excess of tooth structure and removing excess of one important thing, which I want to talk about later also, is the pericervical dentine and how important it is to us. So the next time you are making your access cavities, I want you to think about the pericervical dentine and be mindful of any procedure that you do related to the tooth. Make sure that you are taking very less from this particular structure, and I'll talk about it more in detail. Okay, so newer concepts basically have a balance between all these three factors. It cannot be always the convenience of the operator, right? We have to think about the tooth needs also. We have to think about the restoration needs also. Okay, as we saw in the objectives of the access cavity preparation, the third was conservation of tooth structure. So we cannot be making access cavity in a way that ends up destroying the tooth, just to do one root canal. You're trying to save the tooth, but look at the structural compromise that you have done now. Is it even functional? You've taken so much from the tooth. So what I'm trying to tell is all these three needs have to be met. The newer concepts have to have a negotiation between all three. You cannot just, traditional concepts earlier were just operator needs, like I need to see well, I need to get this instrument till the apex, I need to make this bigger, 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 but you're taking away from the tooth to make it bigger, right? So the current protocols that we are going to talk about, or that we are going to be mindful when we are doing access cavity preparation, will extend the life of the root canal tooth up to 10-15 years, you know. But whatever we incorporate after this, whatever mindfulness that I'm trying to teach you, the conservative of the pericervical dentine and all those things, maybe this treated tooth can last for up to 20-40 years, So this can be achieved when these three factors are met. Okay. And I'm going to show this to you with an example. Now, look at this first molar of a 20-year-old woman. Okay, this is tooth number 36. Now, these young teeth are actually dangerously hollow to begin with. If you look at the pulp chamber, it's very big, it's very wide. In an endodontist's opinion, this is a perfect tooth for a root canal, right? Endodontists are very happy to do root canals, nice straight roots, big chamber. You'll feel the big drop when you shape it also. It's going to be so beautiful, so perfect. Perfect class 1 RCT, right? The following case is actually a representative of a large percentage of endodontic accesses performed by general dentists and endodontists as well. Most of the most routine case that we get is of a lower 6, right? And I'll tell you what the dentist did. This case I'll show you. So the general dentist created the first access with this using Fisher burrs and with the type of dentine removal that is standard today. You know, the tooth was then reassessed and re-accessed by an internationally recognized endodontist. And this model for generous removal of pericervical dentine, I'll show you, is very, very common among specialty practices. And by the time both of these well-meaning dentists had finished with the tooth, this molar was nearly worthless because most of the important structure were compromised with. Look at the pre-treatment, look at the gouging that has happened. The red arrow you can see denotes the gouging. Come to the blue arrow. The blue arrow indicates the grossly excessive dentine removal that has been done in the pericervical area. You know, the yellow arrow indicates the large canal flaring. Excessively, people used to flare the canals, with unacceptable dentine removal. And this is again in the pericervical dentine area. And the green circle highlights worsening of the lesion on the mesial root ends. 18 months later, that is the recall of the last picture, the lesion on the mesial root continues to enlarge. So what have we done? Look at the pre-op. Pre-op was so beautiful. We should have had a good post-op obturation X-ray for this tooth. It should have been doing well. It had so much tooth structure left all around. But we are doing all these accesses and we think that the root canal done is great. Of course, we see that fill. Oh, the sealer fill has happened. Oh, the obturation looks perfect. We've reached the apex, but the tooth is failing, and this is because of the access. Another question I want to ask, are endodontically treated teeth more brittle and hence more vulnerable to fracture? No. I want to bust this myth. The myth of endodontic teeth being brittle can finally be explained in overtalked dentine that slowly degrades until it finally fractures years and decades later. The endodontically treated tooth doesn't dry out, but a hollowed out endodontically treated tooth is constantly bending. Understand this. You think now moisture loss of only 9% occurs after root canal treatment. So it does not become brittle and breaks. That is not the concept that is happening. That is not the fact. The fact is that if you hollow out the tooth with your access cavity, when you're not thinking enough, when you're meeting only the operator needs that I need to see well, I need to enlarge this access cavity, when you do all of that, you are hollowing the tooth out from the inside. And when you do the post-op restoration and then you prepare this tooth for a crown, you're going to hollow this tooth from outside also. You basically have a very thin sliver of material left, the original tooth material left, and that is where it breaks from. It does not break because the endodontically treated tooth is brittle. It does not break because of that. It broke because you hollowed out the tooth. because you did not prepare it well. Your access cavity preparation did not follow mindful and conservative guidelines, So the structural loss of these root treated teeth requiring restoration, is more. The fracture is because of this. Okay, try to understand it is not because of brittleness, so I want to debunk that myth completely. The bending and the flexing that is happening at the cervical area, the neck of the tooth, where you need to leave more amount of tooth structure, take less from it. Basically, that's what I'm trying to tell. All the bending happens during mastication at the neck area, and this is the area I want to preserve. When you're doing access cavity preparation, make sure you do not take excessively from this area. Okay, so if you have robust coronal dentine, maintained good distance away from the tooth's centroid, which is the cervical area, the tooth will be stiff, it will resist bending and will resist fracturing. So basically, preserve the cervical area of the tooth, not just from the outside, but from the inside also. So why do endodontically treated teeth fail? Because of the stress experienced by the tooth under load. And ideally, they should be able to take the stress. The inherent biomechanical properties of the remaining structure is responsible for resisting fracture. But if you take away all of that structure, then how will it resist it? And that's what causes the failure of the tooth. Not anything else, not the brittleness and all that stuff. I told you the moisture loss is only 9%. So it's not brittle because of you, because of the moisture loss, it's brittle because of you. What are the problems that we have with associated with the traditional axis? One is we use excessively large round burrs. So I want you to switch to smaller burrs, more conservative burrs, and try to remove only that is necessary. If you use these large round burrs, you'll end up with gouging like that happened over here. So this gouging I want you to avoid by using small round burrs, only enough to remove the carious tooth structure and to de-roof and to get access, I want you to stop using GG drills. Please, you need to stop using GG drills. They are not for flaring. They were there earlier, but we cannot flare canals with this. We have good rotary files now with adequate preparation sizes. We can achieve flaring, but GG drills are very excessive and very destructive. Okay. And the third thing is uh, excessive de-roofing. Like in this picture, you can see the de-roofing that they tried to do. They could have managed with only in this area, but when you look at the picture A, they have gone beyond the de-roofing parameters, So be very careful for these three things. Large round burrs remove areas in the dentine, especially the pericervical dentine, which I don't want you all to remove. And GG drills need to be avoided. De-roofing only in the area where the chamber is, nothing more than that. So when we spoke about operator needs, the convenience of me as a dentist trying to gain access to the tooth, uh, we need to also speak about the tooth factors. So I want to tell you what is important to a tooth. So this is the hierarchy of tooth needs for posterior teeth. And you can see way up, right on top of the list for high priority to the tooth itself is the pericervical dentine, And what is this pericervical dentine? Let's get into that. Pericervical dentine, the critical zone, roughly 4 millimeters above the crestal bone and 4 millimeters apical to the crestal bone. This area outside and inside the tooth, basically 3D. We need to conserve this. And why is this so important? It's important for ferrule. It gives you that bracing effect, like how we have ferrule when you're doing post and course, right? We need that 2 mm of ferrule. Exact same thing. This is the neck of the tooth. You need that part, pericervical dentine, to give that fracture resistance, to give you that ferrule for the tooth, the bracing effect, It is also, as I already said, it will help resist fracturing of the tooth. The stronger this part is, the more you leave of it, the more it's going to resist fracturing. And dentine tubule orifice proximity from inside to out. Basically, it's telling in that area where the pulp chamber is, we all know that the tubule proximity closest to the chamber is bigger. So we need to retain these. The more we remove, then our proximity away from the chamber, the size of the tubule reduces, right? We don't want that. We want more of this. How are we going to keep more of this? By reducing less of the pericervical dentine. I want to reiterate that no man-made material or technique can compensate for tooth structure lost in key areas of pericervical dentine. There is nothing that we can put back and say that, okay, whatever we had removed, we have put it back and we have replaced it. There is nothing. The more the dentine is kept, the longer the tooth is going to stay in the mouth. And that is what our aim is, right? We cannot do a huge access, perfect RCT, and then the patient breaking this tooth in a year. That does not work out, right? So let's look at few guidelines for perfect access. Okay, we'll discuss few of these in detail and then I'll give you a technical chart. Okay, visualization of likely internal anatomy. How will you do this? Okay, before you start, you're going to take two periapical radiographs in different angulations to understand the likely anatomy that you will be dealing with when you're doing this access. Okay, I don't want you going in blind. Don't look at a tooth that needs endo and just randomly start digging. No, think about it. Where is the caries? Where is the chamber? Is there any calcification? Where are the canals? How many canals I'm dealing with? Where is the apex? What is the angulation of the roots? All this will help the clinician in estimating the position of the chamber. The X-ray will tell you, okay, how deep do I have to go? I'll get the chamber. Will I get a drop? I won't get a drop. All this traditional, activities for the access cavity is all long gone. We rarely get a drop, right? We all know people who are doing routine endodontic accesses, you need a huge chamber for you to feel that drop. And because we've been taught that way that we need to feel the drop, we need to feel the drop, people keep going deeper till they feel the drop and then that drop is under the furcation, you know. So that is why you need to change your mindset, revise and turn things around and learn the correct things, that there might never be a drop. But what you can get is a pre-op IOPA and understand how deep the pulp chamber is from your cavo surface margin. And that is only how deep you'll go. If you're confused, stop. Please do not go deeper if you're confused. Take an X-ray, see the depth at which you are. You will get a better idea. Okay, maybe I have to go 2-3 millimeters more, right? And then I'll be in the chamber. So a pre-op IOPA and a reading and a studying the pre-op IOPA before you start an endo is extremely crucial. I cannot, emphasize this enough. It's very, very important. Sit down with it. Look at things. You will learn a lot of things. They keep saying endo is a blind, treatment. It's not. You can get a lot of things. The X-ray reveals a lot. Okay. Next is evaluation of the CEJ and occlusal anatomies. Okay. CEJ, as we all know, the study, very famous study done by Krasner and Ranko. I will provide that paper to you. Just message me or, I'll put it in the chat as well. I have a few articles that you all must read for access cavity preparation. So if any of you are interested, just message me and I have a few articles that you need to read. So basically, Krasner and Ranko did the study and they found out that CEJ was the most reproducible anatomical landmark, which remained the same in all the teeth that they studied, which means that we can use this as a landmark for doing our access cavity preparation. We all know his laws of, concentricity, laws of centrality. Basically, everything that is inside is a projection of outside, right? Or whatever you see outside, inside you'll find the same thing at the exact same constricted place. So evaluate the CEJ before you start. Then preparation of access cavity through the lingual and occlusal surfaces. Occlusal surface is very normal. We all know this. Palatal is in the upper incisors. But I want to emphasize this one thing. For your mandibular incisors, try and go for a mandibular incisal access or a labial access. This access is much better. It gives you better access to the, sometimes in mandibular teeth, approximately 25 to 30%, you will find a second canal and this will be easily accessible from the labial side. So for mandibular teeth, if you can go with the labial access, if you feel confident enough that you can do it from a lingual access, sure. But your access cavity will be much better if you do a labial access for mandibular teeth. Removal of all defective restorations and caries. You need to remove all old things, and caries removal has to be done completely before you start with your proper root canal or like orifice location and other things. You cannot be like, okay, I'll leave this caries and I'll leave this restoration. You cannot do that. Remove every single thing. It's going to help you a lot, trust me. Because in open preparations, when you have everything removed, all your canals are much easier to locate. You don't know whether beneath which caries or beneath which restoration some canal is hiding. So remove everything that is unnatural on the tooth. It's going to be much easier for you, much easier to locate the canals, the cleaning, the shaping, the obturation, everything becomes much, much, much more convenient. Okay. And also, in case you do it later, all your restorative debris might get dislodged inside the canal. So we don't want that, right? So removal of all this, carious dentine and all that also prevents the bacteria from entering the root canal system when you're doing the cleaning, right? So lots of added advantages. Remove all defective restorations, caries, any unsupported tooth structure. Okay. While you're doing all this, you need to make sure that you have a straight line passage of instruments. You cannot have excessive bending of any instrument. And if you feel that that is happening, please modify the axis and then proceed with the cleaning and shipping. Delaying of rubber dam placement is very important until difficult canals have been located and confirmed. I would say go a step ahead. Delay the rubber dam placement after after your axis only, because you have cases like crowded teeth, rotated teeth, fractured teeth, calcified teeth. The angulation is different, the long axis is different. All of this can hamper your axis cavity. If you have rubber dam placed already, you will lose that orientation. Okay. So make sure you know the correct tooth, start the axis, you have the jawbone that you can see and the angulation of the tooth, make the axis and then place the dam. Okay, so delay of rubber dam placement. This is us being mindful. So can you see how delaying the placement of rubber dam is helping in your axis cavity preparation, right? Because if you probably place the rubber dam, you don't know the inclination of the tooth. Like for mandibular premolars, they're slightly lingually inclined, but if you go straight, you'll have a labial perforation, right? So this is a error in an axis cavity preparation, but why did it happen? Because you placed the rubber dam, you lost the orientation of the tooth, right? So delay placement of your rubber dam. Then location, flaring, exploration of all your root canal orifices. Make sure that you find each and everything. The only thing I would advise in delaying is your MB2. If you found all the canals and you're having difficulty in finding your MB2, don't do excessive preparation and excessive removal of tooth structure to find the MB2. I would suggest pre-flare, clean all the three canals, and once you have a nice clean chamber, then with a fresh mind, try to look for the MB2. This is the only time I will tell. Delay the, exploration of the MB2 orifice. Then inspection of the pulp chamber floor with magnification and proper lighting. You will see everything. You need to visualize that you have the pulp chamber floor only. Sometimes there may be calcified tissue, maybe some stones are there. So you need to remove all of that. That also compromises the, cleaning and shaping that you're going to proceed with further if you have a stone that is blocking the orifice and everything. So it is all part of axis cavity preparation only to get a clean chamber, beautiful, axis cavity, and then only proceed with your BMP. If you have all these obstructions, if you didn't do the axis cavity well, it will obstruct your cleaning and shaping. So make sure that you do all of these things well and then jump to the next step. And the last one, tapering of cavity walls and evaluation of space adequacy for a coronal seal. I'm not saying that excessively enlarge the taper, but as much that is needed to get to the chamber and remove the roof of the chamber, please do the needful. Okay. So to comprise everything together, the pre-op assessment use two-angle radiographs, CBCT for all retreatment cases. Okay, you cannot go in blind. You need to know why previous treatment failed. So pre-op assessment, you will get two-angle radiographs and CBCT for complicated cases. Biomechanical rationale, I told you about PCD, very critical. You're not going to remove it. Outline form will be dictated by the pulp chamber anatomy and not the external crown. You'll have to dig and see the anatomy and follow that. It has to be in the center. to avoid perforations. Your access cavity walls will be smooth and it will be flared coronally. This helps premature binding of the file coronally, and sometimes when you need to get to the apex, the file is binding in the coronal region. So all this flaring that has to be done before only. And mind you, not too excessive, you know. We're not going too traditional and not going towards too much of newer concepts like ninja or truss access, all that. We're not going into that. Incomplete re-roofing will leave pulp remnants, and especially in anterior teeth, there's going to be discoloration and all those things. So make sure that you de-roof completely and clean the pulp chamber remnants as well. So armamentarium, go for a round burr, number 2 to number 4 for initial entry, the endo Z or the endo access burr for de-roofing because it has a safe tip. And you can use ultrasonic tips when you are in the chamber and you want to trough for the MB2, you know, and you're looking for extra canals. Following the laws of symmetry, if you feel like maybe this tooth has extra canals, you'll not be using burrs now. Once you've entered the chamber and cleaned everything, you'll be using ultrasonic tips, and I'll tell you which tips to use. Magnification and illumination, I cannot emphasize enough. Please use basic loops or even a microscope if you have it. You know, MB2 detection is almost as high as 95 to 98% in maxillary molars for the Indian population now. So please make sure that you look for it. Unless proven otherwise, a maxillary molar has 4 canals, okay, not 3 canals. And then you locate all the canals based on all the laws of centrality and the symmetry that you have. Again, the paper I'll share, I'm sure all of you are well versed with it, but if you want to know about it in detail, you can go through the paper. So these are the ultrasonic tips that we have. We have many more tips by different companies. You have Dentsply, Startex tips. 80th is selling those tips. Many tips are available by different companies. These are the two which are very, very famous, very well known. That is the BUC 1, 1A, 2, 2A, 3, and 3A. They all have different functions. It was named after Stephen Buchanan. I think we all know him. He's like the pioneer in endodontics. So basically, these refining tips can be used for delineating, you know, the outlines of the root canal orifice to make them look better if you've not found them well enough, or any removal of any overhanging dentine that is there. All those deposits are removed. All the orifices are exposed. If you have any pulp stones, you can remove them. This is used at a frequency of 20 to 30 kilohertz. And also they are much better because there's no handpiece that is obstructing the vision. You can see the angulation of these tips and they provide that visual you know, access to you to be able to do a much better job at refining your access cavity. You know, these ultrasonic tips are smaller than the size of your smallest burrs. So make sure that once you reach the chamber, once you've done all the cutting, these tips will help you in refining the chamber, you know, to get the best out of your access cavity. Okay. Next, you have visual cues. You have the chamber floor that is darker than the wall, so you know you've reached the chamber. And in case you need to delineate more, you don't need to extend more. If you can see something more darker, you have to extend it because there will be pulpal remnants in that area. You know. Next is the champagne bubble test that you can do in case you're not able to find some canals. Clean the chamber, put just hypochlorite, and wherever you will see a bubble, because there's a hole probably over there, you'll be able to know that there is probably a canal, and you'll then just maybe with a DG16 or a micro debrider or a micro opener, you should be able to find it. Okay. Conservative ninja access preserves the pericervical dentine for sure. Truss access also preserve the dentine bridge. I would recommend not to do these access cavities because current literature proves that there is no difference when you do these access cavities affecting the structural durability of the tooth. So I am not recommend these, the ultra conservative accesses or the ninja access. Don't make them really small that it's making very difficult. Barely from one hole you're not you know, going to access all the 3 canals. The basic rule of endo, I'll tell you, basic access cavity tip, I will tell you. With your one eye closed, when you look at your access cavity, in one shot you should be able to see all your canals. That is how you know you've done a good access cavity. Okay, if you cannot see, then maybe you need to refine in that area to be able to see all the canals with one eye closed. Okay, so next time you can try this. Now lately we've been having better advancements. We have CBCT scanning. They make stents in case you want to do the exact location for a calcified canal and all. All of that is good. All of this is enhancing our access cavity preparation, right? But we don't get such cases routinely. Routinely, what we get, whatever we have told you till now, we can apply it in all the routine cases. Okay. Again, what the common errors that we have is we over enlarge, we weaken the cusps, we do incomplete de-roofing, there's discoloration, there's perforation because the angulation was not right. There's misaligned entry, missed canals, and then there's ledges because your instruments are going, your files are going at all the wrong angles. Everything starts at the axis. Yeah. So you have to correct that, and then everything else will be smooth after that. So, this is a demo. I've done an access cavity for an upper molar tooth, which I want to show you. Just look at the maxillary molar. So this is how you'll delineate. You'll find the palatal canal there, the mesiobuccal, distrobuccal, and you'll start digging in that area. Okay. And you'll slowly go deeper and deeper. Right? It's a very small round burr that I've taken. Keep going deeper, and then you can see this. So this is probably the tip of the chamber, the roof of the chamber. You've barely touched it, right? This is where most people stop. They think that if they put a file through it, they will get the access, and you will get the access to the mesiobuccal canal. But what we need to do is de-roofing, right? So this is what de-roofing is, where you get deeper, and you'll see that the chamber is actually darker than the walls of the tooth. Then you'll irrigate. Look at this. So you can clearly notice that the chamber is darker. We found the mesiobuccal, we found the distrobuccal, we can see a palatal, and we can also see a small MB2 in this case, right? And it's usually hidden in a dentine shelf. When you draw a line from mesiobuccal to the palatal and you drop a perpendicular from the distrobuccal, it is going to lie slightly mesial to this line. Okay. So, and it is exactly there. You can see. So there's also something called the Boeing test to know when you're in the canal. You place a file inside and then you flick it. And if it does not move, it does not come out and it just shakes or it boings in that area, which means that you've confirmed you're in the canal. Okay. And when you want to modify the tips, modify the area, modify the chamber, basically, remove some dentinal shavings in the area, probably from the MB1 to the palatal canal to find the MB2. You will do it with an ultrasonic tip as it was used. So this has now, clearly you can see the MB2 as well, right? And in between, you can see the root development fusion lines. Again, you'll read all this in the paper that I'll share with you. So this was a small demo of an access cavity. You can see how minimally invasive it is. Look at this. So the cavity is only this big. This is not removed too much. If I close one of my eyes, I'm able to see all the 4 canals. And I've not excessively flared anything. I've removed the dentine bridge also to reveal MB2. And I have not destroyed the oblique ridge as well. So this is how a good access cavity preparation looks like. And that is all for today. I hope I was able to provide you with some sort of knowledge, something extra that you could take away. And I hope I didn't bore you with too much information. And I'm open to taking any doubts from anybody that you guys might have. Um,
Hello.
Yeah. Yeah. So I'm just going through the chat. I can see a few messages. Yeah, Thiru has written caries driven access cavity for sure. As I mentioned in the guideline, that we remove all of the caries that we have to do any which way. So it is a caries driven access cavity. How do we balance between achieving straight line access and preserving dentine to prevent weakening of the tooth? See, doctor, whatever needs to go will go, like caries, old restorative material, all of that stuff will go, right? When you're doing the straight line access, what I mean is that if you're able to see your tooth orifices, the pulpal orifices, all of them, if you've removed anything excess of that, that is unnecessary. So that is the balance. So the balance lies between able to see all the orifices, locate all of them, as well as not removing excessively. So that is the balance that you need to maintain. The Boyne test is basically you place whenever you feel you are confused, that you don't know you're in the canal, right? You sometimes when you're removing the tooth for the access cavity preparation, and you feel like, okay, is this a canal? You want to check. Take a file, place it in, and flick the file. If you flick it and it falls off, that means you're not in the canal. If you place the file inside, it's inside a canal, it's just going to shake like that. That's the Boyne test. 1 2 anatomy, we go for till 2 type opening or just single opening? You will go for single opening, only single opening. How to detect calcified canal? There's a lot of dyes that come. It's a bit tough. Also, when you're drilling without water, especially when you're using ultrasonics, you will see all of the dentine mud collect in one particular area, one small spot. That will be probably the area that you need to dig further to be able to get to the calcified canal. Um, Please suggest medium range loops. That is Himanshu. This is cheating. We are going outside the bounds of this discussion. But medium range loops would be, I think you can go for Zoomax. You can go for Ergonoptics. You can try iMag. You can also look at Oricam. They're selling some good ergo loops. Kriti Gupta, I'm unable to locate MB2. So, Kriti, I will start with doing access cavity for a maxillary molar by finding 3 canals. Prepare and shape all 3 of them. Okay. After that, once you've done all of that, from the mesiobuccal canal to the palatal canal, imaginary line you draw. Okay. Once you've drawn this line, from the distobuccal canal, draw a line perpendicular to this line and a little bit mesial to that line that is joining the mesiobuccal and the palatal. You will find exactly in this area, you will find the MB2. And even if you feel like you've not found it, take a small ultrasonic tip, or you can also take these burrs that come by money, this carbide burrs. They are very long shank, very small round burrs. So basically the long shank helps in giving you a little bit more visibility. Remove that area mesial to this line, dig very little bit, you will find MB2 exactly there. And if you still don't, you connect with me, I will help you with your individual cases. Which number of ultrasonic endoscalar tips should we buy? It depends, Dr. Poonam, for what you want to use them. Okay. Is it for just removing the chamber calcifications, or to find canals, or for activation? Just DM me. These are my social media handles. I will guide you accordingly. CBCT mandatory for each and every case to find MB2? No. Assume that MB2 is there. Like, if you think, like, would you say that is CBCT mandatory to find palatal canal of maxillary molar? No. Assume that it's there. You have to find it. CBCT is mandatory only for all retreatment cases. Please name some dye material. Any dye you can use. Methylene blue dye is the best one. How to prepare MB canal properly, because sometimes it's curve and not feel. Okay, this is again, it's for it's in the BMP. But try with pre-flaring first. Okay, so take any maybe 2006 or 2506, but don't insert it fully. Insert it only 3 to 4 millimeters or till where you feel resistance just before that. Basically, I want you to try and make the canal straighter by pre-flaring. Don't put your hand files first. Put your rotary file, pre-flare the canal, make it straight till the curvature happens. And then with EDTA, liquid EDTA. Nobody will use gel wala EDTA. Don't use that. Okay. Use liquid EDTA and slowly with the help of your 10 number K file, which is going to be your handyman, then negotiate. Then again, choose a smaller file. Choose 2004 or 1304 or the glide path file and then go deeper. So basically, you're doing a sort of crown down technique. You're making it easier to get to the apex. After you do all of this, then you'll put your 10K hand file, then measure the working length. Till then, don't measure working length. How to trough for middle mesial and how deep you have to go. You will go only as deep as the mesiobuccal and the mesiolingual canals. You will not go deeper than that. So if you place the, suppose you're using an ultrasonic tip, right? Or you can use a diamond coated ultrasonic tip, or you can also use a small, the money burr that I told you, because it's very less destructive. It's a basically, it's an MI burr, which is minimally invasive. It will not cut excessively on dentine. So when you take that and just, shave it over the two orifices, utna hi you have to do. And you should be able to all this when you're digging over here, na, the debris will collect in a spot. That is your canal. MB2 is in maxillary molar, highest percentage. Maxillary second molar, third molar also. It is present, but in lesser percentages. Like I think around 60 to 70% for your maxillary second molars, but it is as high as 96% for first molar, which is as good as present only. So 4 canals. So that is why I told you will look for it. Try to look for it after you've done cleaning and shaping, and then see, okay, can I find an MB2 here? Like that. Doctor, can you please name some pulp detectors? I do not understand this question. Are you talking about pulp sensibility testing, or I don't know? In one of my cases, I'm unable to find MB2 and there is one extra palatal too. Tried last appointment, did not find. Um, I don't know. I mean, I already told the how to find the MB2 canal, so probably you can follow that guideline or just DM me. I'm not able to understand. Like, great, you found an extra palatal canal. But check for an MB2. Don't be aggressive. If it's not there, it's not there probably. In pediatric cases, which number rotary file? You don't have to go pediatric, it does not matter as long as you're able to create enough space to clean and just fill with your metapex is more than enough. Um, Pediatric endo, I follow the files we get by Kids E Dental. They have that small assorted system. I use that. How to not perforate premolar while access opening. Most of my failure goes in premolars. So you are going to do not place a rubber dam. Evaluate the long axis of the tooth and make sure that you angle. We know that the premolar is going to be slightly lingually tilted. It's going to be inside. So don't go this way, go this way. I hope I was clear. How to perforation repair after giving MTA, how many days to put the repair for. So if you're using MTA, which has a setting time of over 3 hours, you're going to place the MTA and then you're going to put a moist cotton, and then you can recall after a day. You don't have to wait for too many days. A day is more than enough because the setting time is almost 3 to 4 hours. You can also go for fast setting MTA and biodentine. They both set in 10 minutes, which you can wait, put a timer because you obviously all you're doing is under the rubber dam. So I place a timer and I leave and I come back only after 10 minutes and it has hardened and you can just directly restore on top of that. I hope I have been able to solve everybody's doubts. There were too many questions. If there's more, I'm ready.
Thank you, Doctor. I think we will wind up the session for today. And I'm really sorry for the technical error which happened earlier. Once again, thank you so much for sharing your knowledge. and expertise when it comes towards managing this session. Surely many of us would leave this session with amazing takeaway points and implement techniques as per discussed. Thanks to all doctors for participant listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. Once again, thank you so much, doctor. It was a wonderful and informative session, and we really appreciate your valuable time given to us for this series episode. Please do check out and follow Dr. Urvashi ma'am's Instagram page where you can appreciate her clinical works. And to know more about our upcoming webinars and workshops, please do check out our website, which is iadpe.org, or you can follow our Instagram and Facebook pages as well. And if you have missed our previous webinars, do check out YouTube channel as well. And we really appreciate if could subscribe as well. So thank you all and have a great night.